Good morning, I'm Mercy Wahome. I worked as the analyst. So the results mainly the work that we did with a lot of support from the county. So actually these are results by concern, the county and ACF, who are our main technical advisors on this. So that's a background, a short background on Mukuru. We know that Nairobi County, being the capital, has a very large population, and 60% of the total population is in the slums. Mukuru and Viwandani are among the major slums in Nairobi. And others include, of course, Kibera, Kawangware, Kayole, Soweto, Majengo, Gatina, and Gitare. That's the map of Mukuru. And I added this slide because there was a question on sampling. I don't have a pointer. This is Mukuru and Viwandani. So you can see we have blocks. So in terms of sampling, we divided the area in blocks and then further went and subdivided them. You can see, for example, Gatope, there are about 3 blocks. So in all that, we came up with clusters, and then we had the 3-stage sampling, where now we picked the households from the clusters. So those are blocks, for example, in Riara, one of the villages. So the overall objective was to estimate the prevalence of known risk factors of undernutrition among children aged between 0 to 59 months or 5 years in order to understand the impact and severity of the risk factors. We ended up with 32 clusters, that is 16 in Mukuru and 16 in Viwandani. And each cluster, we picked 24 households that were sampled randomly. So in terms of findings, I really want to go into the findings and not the other part. And then we can be able to discuss more. And you can write your questions because the slides are a bit many for that. So in terms of findings, we found that Mukuru and Viwandani has generally young population, with most of them being between 20 to 35. We have some who are born there, but a large population are immigrants from the rural areas. Especially those under 18 born in the area. Most of them work as the casual laborers in the nearby industries, and we found one in Maleba that had very, very many, I think over 1,000 women, and most of these women were single. So the other residents who are not in factories engage in small businesses, selling foods, vegetables, running hair salons. There was a concern because we found a number were collecting garbage and selling to industries for recycling. The women, there again a number who go to wash clothes in the nearby estates. In terms of housing, most of the houses measured 10 by 10, made of iron sheets, and we found now they are going, upwards. They are now making story buildings. So it's a real concern when it comes to population, ventilation, and sanitation issues. Most of the families had 5 people, mother, father, 3 children. Where they had less, you could find a relative with them from the rural areas. So on average, that 10 by 10 housed 5 people. Like I said, most of them were single parents, And we got this from the qualitative inquiries, but from quantitative, we found a different, we found it different, but we'll be able to explain why. So in terms of education, this being Nairobi, we expected a higher level of education, but we found this was the distribution of education level, and you can see the non-formal, not completed primary and primary education accounts for about almost 42%, which is high for a population, in terms of the low level of education. And when we look at primary, it could be even grade 2, grade 3. That is a population that cannot rely on written material for any instructions. We sought out to inquire their definition of nutrition and undernutrition. And most of these people recognize the lack of a balanced diet as a main cause of child undernutrition. Just asking them, why do you think it is important for children to have a meal? And they would say yes, and a balanced one. But what was surprising was that majority of them described a balanced diet as a diet that had fish and meat. And in terms of the group, we had those who said, yes, we have been taught about a balanced diet and the groups of food, and a meal needs to have 3 different types of food. So you ask them to mention the food, and they mentioned potatoes, rice, and ugali, because for them, 3 means 3 types of food is just whether there is protein or vegetables, they don't understand. So again, it challenges our quantitative inquiries. When we have data that says community is taking 3 groups of food, what exactly does the community understand? So we had about 15 hypotheses, and how we developed the hypothesis was the first thing that we did a landscape analysis. This was secondary data analysis, because we appreciated the fact that other organizations had done a lot of work in Mukuru. There was a lot of research that had been done in the areas, notably work by APHRC. They have done a lot of work in Viwandani, and therefore that formed a basis for some of the work that we did. Concern also had done smart surveys, the last one being in 2014. So all this information was taken into consideration, and that is when we developed the first set of hypotheses. So we subjected the hypothesis to a group of experts, of course guided by the county government, the nutrition office, and they validated the hypothesis. So we went out to test the hypothesis after that process. And these were the findings. And after that, we presented those findings to the community. We had a rating exercise with the community, and they confirmed, yes, this is information from our community. So they could identify with it. And then from there, they rated the risk factors. Last week, we had an exercise where the experts who had been in the first workshop, again, looked at the results, validated the results, and also came up with a rating. So at the end of this, the factors that scored highly will be, I will present that as the final rating and risk factors by both the analyst, the experts, and the community. So the first one was we were looking at the daycares, and we found daycares were a great necessity in the urban slums. Given that most of the people have to go out to look for work, most of the families are run by either single fathers or single mothers, then daycares become a necessity, and they consider them as a safe place for the working parents. So the state of the daycares are very wanting. Most of them operate from 6 a.m. to 8 p.m. In some cases, we found children who had been left overnight in a daycare, where a mother would go and not come back from work, and then the child has to overstay. We found that they were not run by any professional staff, and most of them were run by either ladies who were previous house girls or grandmothers who are now feeling they were too old to go and look for employment. We also observed a lot of overcrowding in these centers, very poor ventilation. Remember, the size is still the 10 by 10. So we found in some of the centers as many as 60 children. And they had no limit as to the age of the children. So the very young ones who are 2 months, 3 months old, who were not able to who needed support, were put in basins, the wash basins, and they were made to sleep, of course, on mattresses throughout the day. The next one was the issue of non-optimal complementary feeding practices. We found that there was a problem, a big challenge, and most of the parents reported that the point at which their children started taking complementary feeds, that was the beginning of diseases, especially diarrhea diseases, because of the handling of this food. Again, there was very little information on what a child is supposed to be given. What do you use to wean the child? And most of them were given ugali. This is made from maize meal. Vegetable soup, so they would make green vegetables, and they would use the water to dilute the ugali for the children. Mashed bananas mixed with potatoes, rice, and they considered colored rice as more nutritious, so they would color it with a tomato or a carrot. And this was the food for children all the way up to one year old. After that, the child would now be allowed to eat what the others were eating, which was mainly ugali and sukuma wiki. So in terms of engagement of the men reported that fruits were very important. This came out very strongly from the men's focus group. They felt the fruits were important, and they participated in buying this for their children. And they did this when, taking walks in the village in the evening, or, going to their places where they would go and discuss football, and what they would go with a child who could walk. And it mainly happened to be the boy child. So they felt there was some preference for the boy child in terms of, going with them to the resting place or the social place, and also in terms of nutrition, that the boy child needed to be given more food than the girl child. In terms of non-optimal breastfeeding practices, that is the data. And most of you can see we had a high number of people who said they had ever breastfed. But when it comes to continuous breastfeeding, there is continuous breastfeeding at 1 year. When we have 86%, that looks very nice. But from the qualitative data, the contact hours for breastfeeding at 1 year were very, very minimal. In fact, it was only at night, just a few hours in the night, and they considered that as breastfeeding. So again, the importance of having both qualitative and quantitative data, because the numbers can at times be deceiving. So all the respondents understood the importance of breastfeeding. And like I said, most of them are breastfed at night. So when we look at most of the children being left at the daycares, then the question is, do they really breastfeed enough if a 2-month-old can be left at the daycare. So our question now to the daycare operators was, if a child is brought to the daycare with some breast milk, would you be able to give this to the child? And in most of the places, they said no. I think it's only one place that the daycare operator said yes, but most of them said no. And I have quoted what one said, her concern was she would need to taste the milk before giving the child for temperature. So the issue was, no, I cannot accept to touch it. So there's a feeling that that is like part of a body that you cannot have in a bottle and bring to a daycare. So in terms of maternal health, this was encouraging because most of the mothers had attended ANC and at least 4 ANC visits. But again, the question is, after attending the ANC, this delivering. So they said that they were delivering in health facilities with assistance from a health provider. But when we sought to ask where the health provider was based, we realized that the chemists that operate in the slums were also acting as the delivery centers. And they were preferred because they would take credit. So the mothers would say, I can go there, give my radio, give my telephone, pay 500 shillings. The total cost is 2,000 shillings. So I can pay the rest slowly. So the other question was, the government facilities are free. Why wouldn't you go there? And of course, there were all these issues around the distance. Most of them do not operate. The ones that are within Mukuru and Viwandani do not operate 24 hours. There were issues around being questioned about their HIV status, so fear of stigma. So all this made them, and then also the time that they stay. We visited one of the facilities. This is not a chemist, but a proper facility that was providing maternal services. It was very, very clean. A private facility that was very, very clean. They charged 3,800. We actually witnessed a delivery at the facility when we were there, and the treatment by the health providers was amazing. In fact, they had taken a traditional birth attendant who was known in that community, and they had integrated her in the service provision, and she was there as a birth partner, just encouraging the mother and helping her initiate breastfeeding. So that we thought was a very good thing, because in most cases, traditional birth attendants go underground because of the treatment by the administration. So micronutrients, the fact that they went to the facilities meant that they were given the necessary micronutrients, especially the iron. But quantitative data brought it out that only 37% had taken iron folate for more than 90 days. So again, we have an issue with compliance there that we thought need to be checked. The other one was the non-optimal psychological care for women and gender-based violence. Domestic violence was found to be a very common problem. They even joked about it, that on the 15th and 30th of every month, there was a lot of screaming going on, with the men coming home late and the ladies demanding money, and a fight comes up, but they talked about very casually. But the effect of that on nutrition, and especially the nutrition of children under 5, is what we were concerned about, because they used the children as bait and also as a way of punishing each other. So a mother would make sure that she doesn't prepare any food so that the man comes and finds hungry and crying babies so that he can respond to giving food. In our discussions with the health providers, even last week, they confirmed that they had seen an increase in the number of patients around the mid-month and end-month, with mothers taking their children to hospital claiming that they are sick so that they can get prescriptions and therefore get some money from the men. So there are issues about there are a lot of psychosocial issues and gender-based violence that trickles down to the under fives. The fact that we said most of the mothers were single, we found a new definition of marriage, where two people come together, they stay together, but have no idea of where somebody comes from, their rural home. They cannot confirm whether that is their person's real name, doesn't even know their second name, and, very casual relationships that were defined as marriage. So when you look at the quantitative data, it showed that many were married. But qualitative data clearly brought out that there was no marriage, so there were a lot of single women, because in this relationship, support was not guaranteed. So in terms of perceived social capital, we can see about there was 16% said they had no support at all, but 44% said there was some sort of some kind of support. 21% said they felt there was extremely high support. And this was interesting because it now explains their coping mechanisms. Uptake of family planning, we thought it was low when we were going in, but we found that there was high acceptance by both men and women. Again, the question is, where are they getting the commodity? So a good number on the injection, and they got it from the chemists. But again, a high number reported having conceived while on the injection. So it now starts questioning the kind of method that they are getting, the source of the method and even the dosage. Health-seeking behavior, we found this very, very interesting. Looking at Mukuru, people are coming from different communities in Kenya, so it was a very well-represented population, but they had their own new tribe, the Mukuru tribe. There was the rate of diffusion of practices was amazing. So you find people from Central Province who are not as don't have strong cultural practices, behavior that is seen at the coast or western parts of Kenya. So you could actually not say this is a Kikuyu, this is a Kamba, this is a Luo. Apart from the names, the behavior is really very much the same. In terms of seeking help, especially when it comes to issues of disease, we find a lot of them had complained of their children being sick in the last 2 weeks prior to the survey, with 12% of them having diarrhea diseases, fever 17%, and respiratory infections at 14%. And all these have something to do with the environment. Now, when it comes to health-seeking behavior, the first place they considered was the self-medication. So they would diagnose and then go to the chemist or consult a neighbor. And this is where now the cultural issues come, because a neighbor will tell them, this is evil eye, and this is how we treat the evil eye. Just put water in a basin, put paraffin and some Omo. Omo is a detergent, and wash the baby, So you find they had that very tight peer consultation would now really interfere with their health-seeking behavior. And they would only go to health facilities when the child would, present with very a very severe case. Again, there was the belief that if a child is injected, it is out of evil eye, and then you give an injection, the child will definitely die. Yeah, and they would say, we know because somebody's child, we know a neighbor, a friend whose child died. But when you listen, you can tell that they went when it was too late, and the child had, diarrhea and vomiting, and there was very little that could be done at the health facility. So, access to water. Surprisingly, there are very many water points in Mukuru and Viwandani. The issue is the quality of water. It is government water, coming from the city council, but it is highly contaminated because the pipes run on the surface. So because they have to pay for the water, there are those who feel they don't want to pay the 5 shillings. So they cut the pipes in the night, fetch the water, and then just put them back. In the process, they contaminate all the water that is running into the homesteads. We talked to a water vendor who is also a community leader, and he had that to say, he's very frustrated. He's lived in the place for many years, and he just doesn't know what to do because he can relate the diarrhea diseases and the contamination of water. In terms of the data, we can see the water management risks. There was actually no one who said there was no risk. Everybody felt 51% were severely risky. Most of the water, that is how they used the water. Of course, most of it was for basic needs. This is drinking, 16%. Bathing, 91%, and preparing foods, and for sanitation. Ventilation and crowding, I think I had mentioned this, and there was a relationship between now TB, asthma, and other diseases because of the poor ventilation. This was confirmed at the health facility, and also the community kept saying, we have issues. And worse still, both Viwandani and Mukuru are around industrial areas. So there's also industrial waste, smoke from the industrial waste, which the community is able to kind of, intervene because they go to the factory, they raise the issues, but their own pollution within the community, they don't see that as a major issue. So sanitation, we have beautiful toilets that we found in the area. But the question is, how many people access that? A man told that every day before going to work, he has to put 30 shillings on the table for toilet use for the family. But when we talk to the mothers, they tell us, of course, they cannot use all the 30 shillings in paying for the toilet. So if there is a child under 5, you just put a paper. They use the paper for defecation, and then you throw the paper outside. So and they don't see why they should pay for a young child. So it was common practice, just children pulling down their pants and defecating openly. Even when we were doing the focus group discussions at the health facility, the mothers who had come with their children at the facility, the children found it very normal, and we had to ask the mothers to please collect and dispose of the stool because it's something that they are so used to. So the toilets are there, they have to pay for them, and we realized that availability of the toilets actually determined the cost of the house. So houses that have a block that has a toilet charges more than the ones without. So, but the ratio between the toilets and the population, of course, is not, the ratio is not acceptable. There have been many attempts by different partners to address this issue. And what we found is that one partner had tried to give the families some buckets to use. And they felt that they had not been considered because the buckets, the question was, how do you use the bucket? In a 10 by 10 room that is where you're sleeping and cooking, at what point of the house do you place the bucket? And they would ask, can you imagine the father of the house using the bucket in front of the children? And then there was no provision for disposal of that bucket. So the women would wake up very early in the morning to go and empty the buckets in the river, the Ngong River. And they would be laughed at by the fellow women that, oh, you know, we saw you going to empty your husband's waste in the river at 5 a.m. So it just said that, you know, when coming up with interventions, it's really important to consider their living standards and what is acceptable to the community. I have highlighted the red part because hand washing, there was a question in the quantitative data about hand washing 4 critical times with soap. And you can see it's only 48%. So that just explains why we have all these diarrhea diseases. There are very few water points for hand washing, mainly in hospitals and some schools. Daycares, we did not find any hand washing provision. Liquid and solid waste, we found that there had been some, it's a big problem. You know, there are paper bags and paper bags all over. They are blocking the river. Ngong River is almost not a river anymore. It's just a heap of garbage. And there had been efforts by the youth service to charge every household 20 shillings. And this worked. They were very happy with it. But unfortunately, it is no longer active. You know, they also are waiting to see whether it will be revived because it made a big difference in the sanitation and the environment in Mukuru. And they were volunteering to do it themselves. Access to food, the main problem was fluctuation of food prices. Looking at the area, there is no urban farming that can be considered active or, you know, benefit to the community. So they rely on food from the nearby counties. And we established that Machakos County was the main supply of food to the area. So the moment there are fluctuations of food prices or availability of food or drought in Machakos, then there is some effect that is felt in Mukuru. And therefore, you know, when looking at the slums, I remember there was a question whether you can use this information to work in another area. And I would say no, because it's really important to establish where there are sources of food. So it really has to be area specific. Food security. Food insecurity, you can see 33 plus 24%, that's about 50-60% of the population felt there was moderately and severely insecurity, access to food, which is a high population. In terms of coping strategies, because there are all these issues, the question was, how do you cope? What do you do with when the food prices have gone up or you have no employment? How then are you able to manage? So the first thing was opt for cheap food. And food preparation is an expensive venture at the community of Mukuru and Viwandani. Because you look at you're buying food for the day. You cannot store, they don't have refrigerators. And because of the crowding, they cannot even store cooked the place is generally very warm, so food goes bad very fast. But the other thing was rats. The moment you leave food, that night you'll not sleep because of the rats that will come in your home. So food has to be prepared every meal, with every day. So this is something that we think, when you don't live there, you think, oh, I can just throw food in the fridge, I'll have it tomorrow. I'll throw it in the microwave. This surprised me. You cannot store a meal. So food preparation becomes an expensive venture. We looked at the prices of some commodities generally in the country, and we found that petrol had gone down, Petrol has really come down over the years. For those who buy petrol, the price of petrol has come down over the last 2-3 years. Now, when you look at the country, now, unfortunately, the price of kerosene has just been going up by 8%, So you look at the cost of food preparation has just been going up. So what the people in the community do, the first thing is to buy prepared food, the food that is prepared along the street. And they called it, there was chips mwitu. Chips mwitu, direct translation from to Kiswahili means wild fries. Mwitu is wild, and the chips, of course, is the fries. So when you buy chips mwitu, that costs you less than the cost of preparing. And we interviewed some children who are very honest, and they told us, when there is no money, we are each given 20 shillings to go and look for a meal. And with 20 shillings, they could get chips, they could get chapati and soup, chips and soup, ugali and soup. And, the parents felt the soup was okay because it's prepared from, the bones, and there are those women who collect the feet and the head from the chicken parts, the fish that has been removed, fillet, all that. There are people who buy it in the slums. They boil it and they sell soup. So that soup and chapati, and the children love it. So they know when mom doesn't have money, we know we'll have a delicacy. Because when they have money, it's just ugali and skuma. So for them, it wasn't anything that they felt bad about. So, and you can see 93% said they opt for cheap food. And the cheap food has issues with the hygiene. Purchasing food on credit, 81%. This was interesting as a coping mechanism. And that made them frequent particular shops. So we interviewed the vegetable vendors, we interviewed the shopkeepers, and they confirmed. And they had a lot of confidence that these people will pay. We thought it is a good thing. Relying on, the kinship support, 44% actually said you can go into your neighbor, you knock during mealtime, and you get a meal. For those of us here, how many of us can do that? You know that I didn't get a job. I can knock into my neighbors and I can send my child into the other neighbors. So 44% of them can do that, which is again a positive thing. So in terms of dietary diversity, this was quantitative data, but qualitative data just shows that when we talk of 3 food groups, like I said, the 3 food groups, they can have it as potatoes, rice, and mashed bananas. Not necessarily the proteins, vitamins, and carbohydrates. There was a lot of confusion in their level of understanding of the food groups. Now, these were the ones that rated high. And this was, like I said, from the analyst, the community, and the experts rating that we had last week when we presented the results for validation. The one in yellow, was not a hypothesis when we were going to the field, that is the limited knowledge on food groups. We didn't think it was a problem. From the data, we never found it as an issue. But when we went to the field, we had to add it as a hypothesis that ranked very high in terms of its contribution to undernutrition for under 5s. So there are some lessons that we learned, that the high level of diffusion of cultural beliefs and practices, therefore forming the Mukuru tribe, is something that we did not expect. So when you're doing the same in other slums or urban areas that brings together people from different cultural groups, it's important to find out, do they have their own common practices that are a combination of the very small practices from other communities. The strong social networks, these were interesting because they had even a policing system, community policing system, and they have been able to deal with crime. So they know if someone is a criminal, they will steal outside Mukuru, not within Mukuru. We also saw, like I mentioned, the need for community education programs. Looking at their level of education, having workshops and giving them handouts may not bring out much of the results. Modeling is important. They need to see, if we are talking about a balanced diet, we felt there is need for them to actually have it modeled, demonstrated, so that they can see and remember. We found there is need for peer support. I forgot to mention that we looked at the positive and deviant, some positive and deviant behavior. So we found there are people who are in the community that have done so well. Their children are well nourished, and the issue is, can they be peer educators, peer supporters for the rest? There is need for use of audio visuals. We used pictures to get a lot of information from them. Having taken pictures of the food along the streets, and then the toilets, the drains and the pipes, and then getting them to discuss so that they can see what the problem is. Asking them, do you think this is right? What would you want to see differently? How can we stop this? So they need to see, to understand, and to have dialogue. Need for a lot of dialogue. For the community health volunteers, they live in the community, they experience the problems, and therefore they are very dedicated. We need to make use of them, but standardize the information that they give. Because when a community health volunteer gives information to a daycare provider, and the daycare provider says, I was trained, and therefore I advise all mothers to color their rice. So we opened the lunch boxes, and the children had colored rice. And she was very proud of it. So to her, that is a good meal. And you have plain rice with that had been colored using a tomato. And that is because of the information that she got from the community health volunteer. So everybody says white rice is bad. So the solution is put a tomato, get it colored, and it makes a good meal for the baby. So in conclusion, I would say Link NCA, being a structured, very participatory, and a multi-sectoral approach, really brings out the root causes of undernutrition. And moving forward, I think it is a good methodology. So thank you so much.